Hello, and welcome to Talking About Tumors with Ryan and Ryan. I'm Ryan Holstead.
And I'm Ryan Quinn.
And today we're going to round off our discussion around melanoma with a discussion of advanced or unresectable melanoma.
Hope everyone had a great weekend. I know here in New York it was beautiful weather, and I had my last overnight call as a fellow, which is very exciting.
All right, so just before we go into the discussion around metastatic melanoma management, just a very brief recap in the localized setting, keeping in mind that surgical resection for localized disease would be the standard of care. For disease that involves lymph nodes, stage 3 or greater, as well as stages 2B and 2C, there's evidence for using a single agent immunotherapy with some recent phase 2 data showing potential benefit of using this in the neoadjuvant setting, with the course of therapy being given for 1 year. Also for node-positive disease, so stage 3, there's some evidence to use a BRAF doublet inhibitor. Unfortunately, there's still a very high risk of disease recurrence. Even with the use of immunotherapy, the risk of recurrence is approaching 30% or greater in node-positive disease. The most common presentation of metastatic or advanced melanoma is in recurrent disease, so this is not a cancer that usually presents in a de novo widespread metastatic. Often some will have a lesion resected and later things will recur. In high-stage disease such as 3 or greater, this is often in the first couple years, but melanoma is famous for having very delayed recurrences. Notably, Oliver Sacks in the medical field had a recurrence 10 years following his initial diagnosis. Of those that recur, 60 to 80% recur locally or within the regional lymph nodes. And this may be actually a subcutaneous recurrence, so it's good to keep in mind if you feel nodularity at the site of surgery, even without pigmentation, this would be something that raises suspicion and warrants an ultrasound and biopsy. So be very cautious and careful with your exams of the surgical site in patients with resected disease.
Now, talking about the workup for when someone presents with a recurrence, for these patients, you'd want to get a PET CT. There is some data that PET CT is actually superior than just CAT CT, chest, abdomen, pelvis when looking at melanoma. So this is one of the cancers where you would try to get that PET CT if you have access to it. Everybody should also get an MRI of the brain. Up to 1/3 of patients can actually present with brain mets at time of presentation with metastatic disease.
These are really PET-avid malignancies. I learned a new term while reviewing the literature here called the Warburg effect, which is the fact that melanoma tumors do glycolysis even in the presence of glucose, which is how PET scans work. So tumors greater than 5 millimeters can be visualized, which is much more sensitive than some of our other solid tumors when we're using PET scans.
Good to know. I didn't know that term.
The one exception would be with uveal melanoma. This is not necessarily PET-avid. It has a lower tumor mutation burden as well, and is in general always the exception to everything we're talking about. So we'll go into some details about uveal melanoma later.
So you want to make sure to send an LDH for these patients because this can be prognostic in the metastatic setting. If you have an elevated LDH, it infers a worse prognosis. Another thing that's important to send is next generation sequencing, particularly looking for BRAF V600 mutations, because as we saw in the localized setting, there are targeted treatments available. You'd also want to look for KIT mutations because that can also give you additional treatment options, although not very common, but worth checking.
Additionally, NF1 and NRAS are mutations that should be checked for, currently without FDA-approved therapies, but can be helpful, especially as you evaluate for clinical trial options. Locations of the metastases can be very variable. Ryan's already mentioned the high risk of brain metastases. These are prone to hemorrhage. It's good to know some brain metastases are more or less likely to bleed, and these are certainly one of the bleeding variety. Mets can also be to bones, lungs, liver, bowel being a notable one to be mindful of. These can present with bowel obstructions, or sometimes can be a bit more insidious with presenting as iron deficiency anemia. And anyone with a history of melanoma and iron deficiency anemia should have a close evaluation for metastatic disease. If possible, it is worthwhile performing a biopsy. This is not just to confirm the diagnosis, but also to help confirm the BRAF status, which can change in the metastatic setting, as you don't necessarily know what the primary melanoma was. Someone may have a resected melanoma and may have had another melanoma that had gone to that point unnoticed. If the disease is oligometastatic, so that's to say a small number of metastatic lesions, there's no real clear diagnosis of how many lesions goes from oligometastatic to widespread, but typically if you're seeing 1 to 3 lesions that are resectable, that would fall into that definition. For these, the standard is actually to resect the tumor. This is based on a lot of literature in the pre-immunotherapy era, when there was really no effective systemic therapy options. There were a small subset of patients who could have long-term survival. Patients with a single metastatic deposit that was fully resected could have up to a 25% survival at 5 years, which was considered incredible compared to the standard outcomes in these patients.
So metastatic melanoma is historically a very deadly disease. I know, at least even anecdotally, when I was kind of growing up and even fairly recently, always hearing that, metastatic melanoma has a horrible prognosis. Before the era of immunotherapy, the average overall survival was only about 11 months. And the only treatment options that we had were dacarbazine, which was the only chemotherapy that was approved for this and had a very poor overall response rate, as well as high-dose interleukin-2, which was extremely toxic and could only be given in the inpatient setting. So you really had to be at a specialized center in order to get this. Now, once immunotherapy started being used, the first one that was used for metastatic melanoma was ipilimumab, which is the CTLA-4 inhibitor. And the overall survival for this was actually fairly similar to the high-dose interleukin-2, 11.5 months in the first trials. However, given the lower rate of toxicities, this was able to be given in the outpatient setting, so it opened up kind of treatment options to more patients. Once pembrolizumab and nivolumab started getting used, there was evidence that single-agent pembro or single-agent nivo were superior to ipilimumab.
In light of the efficacy of the PD-1 inhibitors as well as the CTLA-4 inhibitors and the fact that these work at different points of the checkpoint system, the trial Checkmate 067 was run looking at the combination of nivolumab and ipilimumab in a 3-armed randomized trial. That would be the landmark trial right now for the management of melanoma. This was a trial that included patients with stage 4 disease and stage 3 unresectable, and randomized them in a 1-to-1 fashion with either nivolumab given at a dose of 3 milligrams per kilogram, ipilimumab given at 3 milligrams per kilogram, or nivolumab at 1 milligram combined with ipilimumab for 3 milligrams. All 3 arms gave treatment for 2 years. In the case of the combination arm, we received 4 cycles of the combination therapy, and then nivolumab was continued a 3 milligram maintenance dose to complete the 2-year therapy. This was a large trial with approximately 315 patients in either arm and has had multiple updated presentations at the time of this recording. The most recent is at 6.5 years of follow-up. Co-primary endpoints of overall survival and progression-free survival.
This trial was only powered to compare the Ipi-Nivo versus Ipi and Nivo versus Ipi. So it was not powered to compare the Ipi-Nivo versus Nivo alone. So looking at the most recent analysis, the overall survival at 6.5 years was 72.1 months for the combination of ipilimumab, nivolumab. It was 36.9 months for the nivolumab arm and 19.9 months for the ipilimumab arm. So definitely much longer for the combination. So looking at PFS, at 6.5 years, 34% of patients in the combination arm were without progression or death, 29% in the nivolumab arm, and 17% in the ipilimumab arm.
This also translated into a survival at the 6.5-year landmark analysis of 50% in the combination arm, 42% in the nivo alone arm, and 23% in the ipilimumab arm. What's really remarkable with this is having seen the 4 years, 5 years, and now the 6.5 years outcomes, there really hasn't been too much of a change in the progression-free survival or the percentage of overall survival. So the total percent of progression-free survival and overall survival has really seemed to level off with a small decrease over the past few years. And this is the tail in the curve that we keep talking about and really is represented here better than in any other tumor site.
So even though the overall survival of the combination arm was, pretty outstanding compared to what we had seen previously with other treatments, it did come with a much higher toxicity rate. 59% of patients in the combination group had grade 3 treatment-related adverse effects, mostly immune-related adverse effects, which we've spoken about previously. The majority were GI-related, so things like colitis, or endocrine toxicities. This resulted in discontinuation in 31% of patients in this group. Looking at the other arms, 24% of patients in the nivolumab arm had grade 3 A's and 28% of patients in the ipilimumab arm. So definitely much higher rates of toxicity with the combination, even though it's only for 4 cycles.
Yeah, certainly a much more toxic regimen. It's important to keep in mind, too, when this trial was started, these were relatively new agents, and sometimes some of the management of immune toxicities were not as good at that time. So we do see some of the more modern trials on both single agent and doublet therapy showing slightly lower toxicities. But even with early recognition and appropriate treatment of these toxicities, the combination with 3 milligrams of ipi and 1 milligram of nivolumab is really a difficult regimen to get through those first 4 cycles.
Yeah, so you definitely want to make sure that you discuss with your patient and make sure that they're aware of things to look out for, like diarrhea, rash, shortness of breath, even things like fatigue that they may not necessarily be that concerned about. You want to make sure that you're monitoring thyroid function and being very vigilant for these toxicities.
Yeah, and a notable population that's excluded from this trial and frankly excluded from any trial, including immune therapy, are people with a history of autoimmune disease. Now, these patients are at high risk for their disease, their autoimmune disease having a flare or having another treatment-related immune adverse event. This is a high yield point for your exams. You might have a patient who has a history of ulcerative colitis or psoriasis, which you may not instinctively think as being a high-risk autoimmune disease, but these really can have a profound flare along with many other autoimmune phenomena. So it's important to take a good thorough history. Typically, someone who has had a history of some sort of autoimmune disease requiring steroids or monitoring is already aware of it, but they may not be so quick to think of something like a colitis or a topical rash. Clear questions that arose from this trial is, we do have patients who are having greater survival with the doublet regimen, but do all patients need this? Can some patients get by with a single agent alone if they have a less aggressive disease? These questions weren't really able to be answered from this trial because it wasn't powered to compare the doublet versus nivo alone. And more recently, some questions have come up to see whether or not changing the dose, namely the flipped dose, giving 1 milligram of ipilimumab and 3 milligrams per meter squared of nivolumab can be an effective option.
So there was a trial looking at this that compared the nivo 1 milligram per kilogram and ipi 3 milligrams per kilogram, which is currently the standard of care. I'm flipping that to ipi 1 milligram per kilogram and nivo 3 milligrams per kilogram. It did show that this did have decreased adverse events and similar efficacy. However, this was a small study, so this is not yet considered standard of care.
Yeah, this was looked at in the Checkmate 511 trial. This was a phase 3B4 trial. They had 180 people in each arm. The primary outcome of this trial was actually numeric adverse events, with the secondary outcomes being objective response, progression-free survival, and overall survival. They did find, using the reduced ipilimumab dose and the higher nivolumab dose, did find that at 12 months, toxicities were decreased from 48% to 33%. Overall response rate did look similar, with 45% versus 50% reported, the lower number being with the lower ipilimumab dose. Median progression-free survival is 10 versus 9 months. So relatively numerically similar, although due to the size of the trial and the statistical analysis, it wasn't powered to really answer whether or not these are truly equivalent. Although less toxic, maybe as effective, still some question marks are remaining over how effective this flipped dose is for melanoma.
Yeah, I think we're definitely awaiting larger studies before making this standard of care.
As I mentioned earlier, we typically would approach oligometastatic disease with surgical excision. Some questions are whether or not these patients need systemic therapy as well. And as mentioned last discussion, the stage 3 trials did have patients with stage 4 disease, although this was typically a small fraction in both the nivolumab and pembrolizumab trial. It did seem, at least in those small subgroups, to have potentially some benefit. More recently, a phase 2 randomized controlled trial was looking at 1 year of nivolumab given at the 1 milligram dose and ipilimumab given at the 3 milligram dose, so the typical dose, and found that at 4 years, the overall survival was numerically greater with a statistical significance of 84% versus 63%. Recurrence-free survival for these resected stage 4 diseases were radically increased from 15% up to 64% with the doublet therapy. As discussed last discussion, there's also been increased questions on whether or not this would be better with a neoadjuvant approach in the same vein as with the single-agent pembrolizumab and nivolumab. And there was at least one trial run by the Southwestern Oncology Group, SWOG, that looked at this with a primary outcome of being objective response rate. Hopefully we'll get some more clear trials for these resected oligometastatic tumors.
So switching over to targeted therapy, about 50% of patients will have BRAF V600 mutations. So again, definitely worth checking this when you have somebody with metastatic melanoma. There are currently 3 different combinations of BRAF and MEK inhibitors that are approved. There's dabrafenib, trametinib, vemurafenib, cobimetinib, and encorafenib, bimetinib. Tongue twister there. So these combinations, they have similar side effects, but they also, each combination has kind of a unique toxicity profile. And given that there's no head-to-head trials looking at comparing these, we typically decide which one to pick based on the toxicity profile.
These are always given as a combination of BRAF and MEK inhibitors, and most of their phase 3 landmark trials were comparing to a BRAF alone, which has since been shown to be ineffective given resistant mechanisms through alternate signaling pathways leading to MEK activation despite BRAF inhibition. All these trials had similar outcomes. Probably the first one to be approved was the combination of dabrafenib and trametinib. And this was done out of 2 trials, one called COMBI-D, which was comparing dabrafenib and trametinib versus dabrafenib alone, and COMBI-V, which was comparing these to vemurafenib. These trials ultimately were looked at in a combined analysis and did find that the 3-year overall survival was 44 versus 32% when giving these agents continuously. The primary side effect for dabrafenib and trametinib is fever, with up to 50% of patients developing a high-grade fever. Also, rash and diarrhea approach 20% in frequency. The fevers often will require dose reductions or pauses, and it's important to know this is not an infectious fever, but more a centrally mediated one.
So vemurafenib, cobimetinib tends to be the most toxic, so it seems to be less used than the other 2. These can have issues with photosensitivity, rash, elevated liver enzymes, as well as diarrhea. Encorafenib and bimetinib, the important toxicity to be aware of is retinal detachment, so you want to be monitoring for any vision changes. Patients can also have nausea, vomiting.
For those of you who are in preparation for your board exams, it's always good to know about the uncommon side effects, and certainly we don't often hear about retinal detachment with drugs. Some do it, so keep that in mind for things like encorafenib and bimetinib. And kind of an unusual one for the vemurafenib and cobimetinib is keratoacanthomas, which arise actually in about 10% of patients.
All of these agents can cause QTc prolongation, so you want to keep that in mind when looking at the other medications patients are taking. Can also cause hypertension, rarely can have heart failure, and as we said, they can all cause fevers. The dabrafenib, trametinib tends to be better studied in patients that have brain metastasis, as these patients were more included in the trials, so something to keep in mind. All of these agents are radiosensitizers, so if you have someone undergoing radiation, you have to hold the medication.
Very quickly on the topic of brain metastases, if these cannot be surgically resected, often you're going to consider using radiation to help sterilize the bleeding lesions. However, as we just mentioned with dabrafenib and trametinib, there is some central activity, and ipilimumab and nivolumab have also been studied in untreated brain mets and do show some response. So if you have small asymptomatic brain metastases and you want to get moving forward with systemic therapy, that may be considered, but should be done in a careful situation with conferences with your radiation oncologists and people who are familiar treating this disease. Up until a few years ago, the primary options for metastatic melanoma were either immune checkpoint inhibitors, with the preference being towards a doublet regimen, or a BRAF inhibitor. And there's a lot of questions of which ones, for BRAF positive melanoma patients, one of the major questions was which one would be better to use first. And there's risks and benefits of each. And the overall survival, at least in the individual trials, seem to be somewhat comparable. Both seem to have their risks and benefits, and a practical study was run by the ECOG comparing which one to use first.
So this study was the DREAM-seq study. I like that name. It included 265 patients, all treatment naive and all with BRAF mutations. And it was looking at starting with nivolumab, ipilimumab with maintenance nivolumab, and then switching to dabrafenib, trametinib was a combination that they used at progression versus the other way around, starting with dabrafenib, trametinib, and switching to the immunotherapy at progression. The primary endpoint was overall survival, and the trial was actually stopped early because looking at the 2-year overall survival, it was 72% for the group that started with immunotherapy versus 52% for the group that started with the BRAF agents. It was interesting that when they looked at the response to immunotherapy, it seemed to have a better response when it was used first rather than second. It had a 46% overall response rate when it was used first, and the people that got the BRAF agents first, the response to immunotherapy was only 30%. Kind of unclear why this happens, but it seems that you have a better response to immunotherapy when you use it first. So because of this, there's more data to start with immunotherapy and then do the BRAF agents at progression.
Yeah, a really helpful trial answering some important questions. The way they had run it was each year they did an interim analysis and seeing if the significant difference in overall survival was enough to warrant stopping the trial. So this was actually stopped at the 4th interim analysis, so 4 years out this significant difference had emerged. Worth noting that regardless of what patients started with, about 50% ended up getting the second-line agent. Probably not too far away with what happens in practice, because sometimes when recurrence does occur, this can be quite catastrophic with CNS metastases or other significant symptoms from disease burden.
So nowadays there's a push to kind of, give the most intensive therapy first. So then the thought was, can we combine immunotherapy plus BRAF and MEK inhibitors? So using all three together makes you wonder what you would do in the second line if this happens, but there were trials looking at this. The first one was the IMspire study, and this was looking at vemurafenib combined, and it actually combined it with atezolizumab, which we haven't really seen in melanoma yet. And this was comparing it with just the vemurafenib combined alone. It did show that there was a improved progression-free survival, 15 months versus 10.6 months, and no increase in toxicity, actually. However, we're waiting the long-term survival data, so right now this is not really used, so not standard of care, but kind of an interesting trial design. Pembrolizumab was also studied in combination with BRAF inhibitors. This was a phase 2 study, Keynote 022, looking at pembrolizumab plus dabrafenib and trametinib, and this study actually did not have a survival benefit. So right now, there's really no role for using all three agents, the BRAF MEK inhibitors plus immunotherapy in the first-line setting. So given that immunotherapy has really changed the game for melanoma and many other cancers, there have been attempts to try to come up with other immunotherapy agents. One of the most recent ones that has achieved some success in melanoma are the LAG-3 inhibitors, specifically relatlimab. If you're wondering what LAG-3 is, LAG-3 is actually a negative regulator of T-cell activity. So it allows cancer cells to escape the immune surveillance, and this is upregulated in melanoma. Relatlimab is an antibody against LAG-3. This was looked at in the relativity study.
Like CTLA-4, preclinical data did show that this could be combined with a PD-1 agent with increased efficacy.
So this study looked at relatlimab plus nivolumab versus nivolumab alone. If you're wondering why the control group is a little bit weird, we thought the same thing. As we know, the standard of care right now for metastatic melanoma is a combination of ipilimumab, nivolumab, followed by nivolumab alone. However, this study only compared relatlimab, nivolumab versus just nivolumab alone. Kind of an issue, I think, with the control group. It doesn't really help us answer the question of if this is better than the ipi-nivo combination, which we know is the most effective. So this study included 714 patients in the frontline setting, and at the most recent analysis, the median follow-up was 13 months, and the progression-free survival was 10.1 months in the combination group versus 4.6 months in the nivolumab alone group. The 2-year progression-free survival was 39% versus 29%, and the overall response rate was 43% versus 33%. So we know that the ipi-nivo combination is very toxic. As we said previously, 59% of those patients had grade 3 adverse events. So one of the questions was, will the combination of nivolumab and relatlimab have less toxicity? And in this study, it actually did. Only 18.9 of patients had grade 3 to 4 adverse events. Obviously, this is limited by, we can't really do cross-trial comparisons, but it does seem to have a little bit less toxicity.
Yeah, unfortunately, we don't have the exact question that we'd hope to have. We've mentioned a few times issues with cross-trial comparisons, and just for, I don't know if we've gone over it yet, but the reason why this matters is trials differ in the time that they're run, the patients that are being run in these trials, and keeping in mind that these were emerging therapies with the nivolumab and ipilimumab trials, and people were discovering how to manage immune toxicities and recognize them early. This relativity trial was run more recently, so people are a lot more critical, picking up on toxicity sooner. It's very well possible that the level of toxicity is less with this combination, but it may be that people are better recognizing, better treating due to the lessons we've learned from these prior trials. We have a combination that seems to be better than nivolumab alone without substantially increased toxicity. It certainly is exciting, and I think many people are reaching to this now as their go-to first-line agent for these reasons. I'm hopeful that there's going to be some trials comparing this combination to nivolumab and ipilimumab, because as a provider who's trying to maximize your survival benefit in your patients, it really does help us to know for sure which combination is going to be the better combination.
Yeah, definitely. Hopefully they do this trial soon.
I'm sure there'll be more checkpoint inhibitors moving down the pipeline. There's some great papers in Nature showing all the potential combinations that have been looked at so far and continues to emerge. And with more checkpoint inhibitors will come for more potential combinations. And melanoma really is leading the way in our evaluation for this. And I would think that if these if some of these checkpoints are expressed in other solid tumors, you're going to start seeing agents that you first hear about in melanoma start to move their way into other disease sites. We are much further along than where we were 10 years ago managing melanoma. It's certainly an exciting time with survivals approaching 50% or greater at 6.5 years out. That's still not 100%, and patients do progress, although lots of work is underway to find out why some patients don't respond and if there's something unique on their tissue biology. Us in the clinic, we have to find ways to help treat these people the best way possible. So should you have a patient come to you and progress, it's important to keep in mind at what point in their treatment that they did progress and what the extent of the progression is. So if they were treated with the 2 years of checkpoint inhibitors and have subsequently been on observation for X number of years, and they recur, may be worth re-challenging with that checkpoint inhibitor. If they were able to get 2 or 3 years without therapy, they may still be immune therapy responsive. On the other hand, if they're in the midst of their checkpoint inhibitor regimen and they start to develop progression, it's going to be important looking at a different type of line of therapy. If they're BRAF positive, that naturally would be a combination of a BRAF inhibitor and a MEK inhibitor. If they're on that combination as their first-line agent and they progress, then naturally you would reach to a checkpoint inhibitor if there's no contraindications. Whether or not switching to a doublet or single regimen is not really well known at this time based upon the limited evidence out there. If the progression is oligometastatic, you may be able to treat that locally with surgery. Sometimes patients on immune therapy will just have a single point of disease recur. You surgically resect that, you continue the immune therapy, and you may have a prolonged recurrence-free interval following that. Short of those options, further options out there are going to be clinical trials. We just mentioned there's lots of emerging ways of treating this disease, and if your area has clinical trials available, you should really think about that for these patients as they may be beneficial. Beyond that, there's some emerging therapies, but later line treatments have not been so successful. One emerging therapy that has been published, although how clinically relevant this treatment will be is unclear to me at this time, and this is a tumor infiltrating lymphocyte therapy. The drug that's been studied so far is called lifileucel, and this is somewhat similar to CAR T therapy in the sense that we take a biopsy, we extract the tumor-evading lymphocytes. These are grown in culture. Patients are given non-myeloablating chemotherapy. Following that, they're then given these grown T cells, and then they're given interleukin-2. This was actually run in a trial comparing lifileucel versus ipilimumab in the second-line setting. It did show improved progression-free survival of 7 versus 3 months. It was a small trial with a total of 168 patients. It was not powered for survival, but overall survival was estimated 26 versus 19 months. So emerging trial, probably not yet ready for prime time. Beyond that, good old-fashioned dacarbazine had been approved for melanoma. Really wasn't that great of a drug, and I'm not sure there's any role for that in the modern era. But if you have a very fit patient, no trials are available, no other drug lines are available, something that you could consider. It's given as 1,000 milligrams per meter squared every 3 weeks.
Another drug that we don't use commonly because it's, again, not very common, but if your patient has a KIT mutation, we tend to see this in acral or mucosal melanoma. There is data supporting the use of imatinib, so you can try this for these patients.
Lastly, before we kind of tie everything together here, uveal melanoma. As I mentioned earlier, this is kind of the oddball of the melanomas. It's not PET avid and generally resistant to immune checkpoint inhibitors. Trials looking at the combination of nivolumab and ipilimumab show about an 18% response rate, which is much lower than what we've seen in the cutaneous melanoma setting.
So one drug that has gotten a lot of attention recently in uveal melanoma specifically is tebentafusp. Hope I'm saying that right.
Rolls off the tongue.
So this drug is specifically for patients with an HLA A0201 genotype, which actually is about 45% of patients with uveal melanoma. And this is a T-cell engager. So my friends that are going into CAR T and T malignancies will be very excited about this. So there is a risk of cytokine release syndrome, and right now this drug is only given inpatient. So what this drug does is it brings together the HLA, which is expressed on the specific melanoma, and it brings it to the CD3 on the T cells. So, it brings it together and then the T cells can kill the melanoma cells, to put it very simply.
Another name for the HLA protein is glycoprotein 100.
So again, this does come at a risk of cytokine release, so you want to monitor for fevers, hypotension. Again, this has to be given in an inpatient setting.
The trial that looked at this compared this agent to what was called investigator's choice. This trial was run between 2017 and 2020, and investigator's choice options were either pembrolizumab as a monotherapy, ipilimumab as a monotherapy, or dacarbazine as a monotherapy. Kind of unusual control arms, especially given that there was some evidence that the doublet therapy could have been effective for these patients at that point. The 1-year overall survival is 73% with the tebentafusp versus 59% with investigator's choice, median overall survival being 22 versus 16 months. Just under 90% of patients developed cytokine release syndrome, although these were typically not greater than grade 3, and none of these were fatal. Although kind of an exciting therapy with a good response rate, unfortunately the trial was run with a strawman control arm, and it's unclear if this would beat Nivo/Ipi alone, or if you have access to it, you have someone with the genotype, certainly something to consider. And certainly if you're interested in running a clinical trial, seeing if you compare that to Nivo and Ipi, because this seems to be a complex drug to give. I'm sure with increased cost and time to actually, it'll be good to know how effective it is compared to what would be the gold standard otherwise.
Okay, so I know that was a lot, as usual, so we'll end with, some bottom lines. So right now, the standard of care based on the Checkmate 067 study for patients with metastatic melanoma, at least in terms of immunotherapy, is nivolumab 1 milligram per kilogram and ipilimumab 3 milligrams per kilogram every 3 weeks for 4 cycles, followed by maintenance nivolumab 3 milligrams per kilogram every 2 weeks for 2 years. And this is based on the Checkmate 067 study.
Although this is a gold standard, there are some emergent therapies that are looking to see if we can maintain the significant benefits that we're seeing in the tail on the curve with the Checkmate 067 trial, namely with the flipped dose, using a higher dose of nivolumab, a lower dose of ipilimumab, or using the novel LAG-3 inhibitor, relatlimab, combined with nivolumab. None of these have been directly compared with an overall survival powering to the Checkmate 067 regimen. So I think the jury's still out on whether or not these are as good, despite having potentially reduced toxicity.
Yeah, again, important to point out that almost 60% of patients had grade 3 adverse events with the combination. Now, if you have a patient that has a BRAF mutation, based on the DREAMseq study, we would start with immunotherapy and then switch to BRAF and MEK inhibitors at progression, because this seems to have a better overall survival.
It's important to be mindful that if you have only a single or maybe a small number of metastatic deposits, that these may be treated surgically. And although radiation may not be ablative for melanoma, can have a palliative effect for symptom control, whether those are in spinal or CNS lesions. Although we've seen great gains and truly remarkable improvements in survival in this previously invariably lethal disease and improving survival to around 50%, for those that do progress on the checkpoint inhibitors and BRAF agents, we still have a limited arsenal in the later lines and start using clinical trials if they're available to you.
Okay, I think that's it. Hopefully everyone has a good weekend. Happy Mother's Day to all the mothers out there. Only job that's better than oncology. And hopefully everyone enjoys the nice weather.
If you're listening to this many months in the future and it's cold again, well, I hope you still enjoy your time. We thank everyone who's been listening along. We've mentioned this a few times, but please, if you are enjoying this, please let your co-fellows or residents know. If you've been following along on the podcast, please subscribe. This helps other people find our podcast. The more subscribers we have, the higher we show up in the search. If you use the Twitter, please follow us on Twitter. We're very grateful to my colleague and friend Vishal Gawali for tweeting out his enjoyment of the podcast. If you do not follow him, we highly recommend it. He is a very brilliant person when it comes to analyzing data. Bye for now.
Have a good night. For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.